This is a learning session on pediatric anesthesia. A pediatric patient is a special patient as far as anesthesia is concerned because a child is different from an adult from a physiological, anatomical, and metabolic point of view. Hence, a pediatric patient poses a special challenge for anesthetists, and pediatric anesthesia is associated with a higher morbidity and mortality. So in this learning session, you will see how a child is being anesthetized for a cleft surgery, and obviously the child is a very small child with 4 months old and about 4.5 kilograms body weight. So this patient is different from an adult patient in every respect, and there will be special things being done and modifications from an adult anesthesia from the time of the child entering the operating theatre to leaving the operating theatre. Now the patient is taken into the operating theatre. This patient is a 4 months old child coming for a cleft lip repair, and the patient's mother is also taken into the operating theatre. At the entrance to the operating theatre, the patient's identity is verified by a nursing officer. Patient's name, age, sex, hospital registration number, name of the surgery, site of the surgery, name of the consultant surgeon, and the name of the consultant anesthetist are checked. Next is to see whether the patient has consented for surgery and general anesthesia, and whether the consent forms are duly filled. This colored form that is shown is the WHO, World Health Organization recommended checklist before operating procedures. Now the patient is taken to the operating room with the mother. So taking the mother in will keep the patient comfortable and less anxious. You can see the nursing officer in charge of the operating theatre accompanying the mother and the patient. Now the baby is kept on mother's lap for induction of general anesthesia. You can see an anesthetist taking a pediatric breathing system with a face mask for induction of anesthesia. The face mask is placed on the face of the patient, and oxygen and anesthetic gases are open. The anesthetic agent that is used here for induction of general anesthesia is sevoflurane, which is a volatile anesthetic agent. For further administration of medications, intravenous access has to be gained. Intravenous access is gained through small intravenous cannulae. Once the baby is anesthetized, the baby is taken to the operating theatre table and anesthesia is deepened further. You can see the anesthetist squeezing the anesthetic bag and deepening the plane of general anesthesia further. Here again a mixture of oxygen and sevoflurane are insufflated to the lungs of the patient. Meanwhile, baby's shirt or the top is removed to set up monitoring, and the anesthetists are looking for a vein to cannulate and establish intravenous access. So monitoring is being set up now. 5-lead ECG, non-invasive blood pressure, pulse oximetry, capnography, anesthetic gas analysis module are primarily being set up. Gaining intravenous access in a child or in a baby is generally not easy because their veins are very small. So you either apply a tourniquet, or an assistant can hold the leg or arm tightly of the patient to get a vein more prominent. Usually for a child of this age group, a yellow cannula which is of 24 gauge or a purple cannula which is of 26 gauge are used. And then the intravenous drip is connected to the intravenous cannula. In pediatric patients, you have to be extremely careful about the intravenous fluid infusion rate, because if the patient is infused too much of intravenous fluids, the patient will go into pulmonary edema and heart failure, which is associated with very high morbidity and mortality. Therefore, a calculated volume of intravenous fluid is taken to a burette set and then infused in a controlled fashion to the patient. Now, further administration of medications is through this injection port. So, atracurium, a non-depolarizing muscle relaxant, is administered at a dose of 0.5 milligrams per kilogram. Intravenous morphine as an analgesic at a dose of 0.05 milligrams per kilogram is administered, and tranexamic acid 10 milligrams per kilogram body weight is administered to reduce intraoperative bleeding. Now you have to keep looking at the monitor, follow vital parameters. You can see end-tidal carbon dioxide, which is an indicator of how much of carbon dioxide is coming out at the end of expiration, and the ventilator rate are being monitored using this capnometer. Now this multi-monitor shows two ECG tracings of two different leads, lead 2 and lead 3, a heart rate between 131 and 132 beats per minute, and an oxygen saturation of 100%. Now the anesthetist is going to intubate the patient or to pass a breathing tube with a laryngoscope held in the left hand and a 3.5 millimeter size south ray endotracheal tube held in the right hand. If the correct size of the endotracheal tube has been selected, angle of the south ray endotracheal tube should come onto the lower lip. Now the patient is intubated, and nice gentle squeezing of the anesthetic bag for controlled ventilation is being done here. Vital parameters are monitored on the monitor, and the endotracheal tube is taped to the lower part of the face. Make sure the capnometer adapter is tightly fitted. Eyes of the patient are covered for protection to avoid injury to cornea or the eyeball. And now the patient is connected to the ventilator. And the anesthetist is packing the throat with a throat pack to prevent pulmonary aspiration. You know, in a cleft surgery is performed in the mouth. Therefore, there's bleeding into the oral cavity. In pediatric patients, we do not inflate a cuff in the endotracheal tube to avoid undue pressure on the tracheal mucosa. Narrowest part of the airway is at the cricoid cartilage, which sits relatively tightly around the endotracheal tube. However, to make sure there's no pulmonary aspiration, the throat is packed with a pack around the endotracheal tube. The patient is turned, bringing the foot end of the patient to the anesthesia machine so that the maxillofacial surgeon would have more room at the head end of the patient. There's room for the surgeon, surgeon's assistant, assisting nurse, and the instruments trolley. A bubble pack is placed covering the patient to prevent hypothermia, using it as a warming blanket. Otherwise, due to the low temperature in the air-conditioned operating theatre, there's a very high chance for the patient to become hypothermic. Now the patient is connected to the ventilator, airway pressures are optimal, All vital parameters are stable. The patient's heart rate is around 120 per minute. Oxygen saturation is 100%. End-tidal captometer shows a reading of 34, and the blood pressure is normal with a blood pressure of 74 by 37 millimeter mercury. Anesthetic gases are being monitored and those are normal. And the surgeon is starting the operation now. After 1.5 hours of work, now the surgery is finished and the anesthetists are recovering the patient. Patient's mouth is sucked and dried. Throat pack is removed. There's no bleeding or oozing and all vital parameters are stable. Anesthetic gases are switched off. Patient has resumed spontaneous breathing and now is the time to reverse neuromuscular paralysis. Patient is now awaking more and more, and now the endotracheal tube is removed or extubated. When the patient's vital parameters are stable and the patient is awake, no bleeding or oozing, the baby is taken to the recovery area of the operating theatre. In the recovery area also, the patient again is being monitored by recovery nurses. Oxygen saturation, heart rate, pulse rate and the blood pressures are being monitored. Nurses also look for bleeding or oozing from the surgical site. If there is excessive saliva or respiratory secretions, those would be sucked out. And next is to hand over the patient to the patient's mother and to take the child to the ward.